Sorry, the link dropped.
The line dropped. Yes.
Let's try and see if we can finish everything within 15 minutes. Was
Okay.
I taking any question before I dropped, please?
You were
No,
talking
sir.
about
Yes,
managing.
my strategy.
Yes, your strategy.
Yes. So for me, what I do is, I said mild is usually 10 to 11. So for mild anemia, I'll convince you so that you get either ferroglobin or bioferron. And then I like the capsules and the syrup. So I'll just tell you take once a day. Because if you buy the syrup, it will just get finished within a week. And still a patient will come and be telling you, I'm feeling dizzy and all that. Once you're taking it once a day for 30 days, then you are confident by the time the patient comes to you, you would have added about 2 grams per deciliter to the HP. So for mild anemia, I usually go oral. Okay, so I'll put you on that. For moderate anemia, for me, I would put you on Totima. Okay, or if you can afford iron sucrose, I will start you on iron sucrose first, where moderate anemia means that between 7 to 9. I'll put you on iron sucrose. Iron sucrose is IV iron or parenteral iron. So I'll give you 200 milligrams every alternate day. So 200 milligrams, 200 milligrams today, 200 milligrams the day after, tomorrow, 200 milligrams, like that, alternate day for 3 cycles. And then once I'm done, I'll put you on Totima. Totima, we all know how Totima looks like. It looks like the ampoule. So you break 1 ampoule in the morning, 1 ampoule in the evening for 1 month. By the time the patient comes to you, the HB would have shot up to like 12. Okay. So that's how I manage my moderate anemia. So I'll give you IV iron, alternate days for 3 cycles. Then I'll put you on Totima, 1 vial BD for 30 days. If it's severe anemia, I'm thinking of a possible referral for transfusion. If it's severe anemia, and then maybe your HB is around 6.5, and I know it's iron deficiency anemia, I would still go ahead and manage you like how I manage the moderates. But if it's around 5, I'll refer you for possible transfusion if I don't have. Okay. Some specialists too would want to say, iron deficiency anemia is HB is around 5. Patient is not really symptomatic. Let's do IV iron. So IV iron sucrose, 200 milligrams alternate day, 3 cycles, and let's do Totima. The focus here is to just push the HB above 7 for the patient to be in the moderate range. Then we'll gradually be pushing it up. I'm trying to say that even though transfusion is good in severe anemia states, if you know your patients can be managed on outpatient basis, don't stress your patients with transfusions. Not everybody is comfortable with transfusion. So if you can do something about it, target and then give IV iron for 3 cycles, alternate day, and discharge the patient on Totima instead. Sometimes we combine IV iron with subcut erythropoietin or synthetic erythropoietin so that you can make more red blood cells faster. It's like we are giving you more hormones, more iron to make red blood cells faster. In so doing, we dodge transfusion and we don't transfuse. Most physicians and most gynecologists are trying to move away from transfusion, unless, of course, it's really needed. Unless you are going to do a surgery where we know you bleed, so we need to give you blood and all that. We'll think about that. But if it's something we can manage you on outpatient basis, we'll admit you slightly, few hours, give you the IV iron, we observe, you go home, and then you take your subcut erythropoietin, and then you continue your parenteral iron till you are done with your 3 doses. We switch you to Totima. We'll combine the Totima with vitamin C so that you'll be able to absorb the iron more. Once you do this combination, iron with vitamin C and possibly erythropoietin, the HB will come up. Okay, so you have options. If your patient says, "Doc, I don't want transfusion," don't force the patient. You can do IV iron, then you convert to Totima, you add vitamin C to it for the patient, and you can even put the patient on erythropoietin for 1 week. Okay, then you are good to go. Usually we give within a week, we'd say take about 2 to 3 injections within 1 week for the erythropoietin. Okay. All right, so time is fast spent. So I'll go on to megaloblastic anemia. Megaloblastic anemia, as the name suggests, megaloblast means the cell is big. Your red blood cell is big. So in this case, when you do your full blood count, your MCV comes, and then your MCV will be what? Will be bigger. Okay. Once you have that, we say you have megaloblastic anemia. Remember we said that when the red blood cell is smaller, we say microcytes. When it's big, we call it macrocytes. Macrocytes. So megaloblastic anemia, you have macrocytes, and then you have megaloblast as well. A megaloblast is an immature red blood cell which has become bigger. Okay, so immature red blood cells are usually called erythroblast. But when an erythroblast becomes bigger because of deficiency of folic acid and vitamin B12, we call it a megaloblast. Okay, so in megaloblastic anemia, there is either vitamin B12 deficiency or there is a folic acid deficiency. And in so doing, red blood cells fail to grow properly. You know, you need iron, folic acid, and all that for DNA synthesis. So once you have a deficiency there, making cells become a problem. So you're unable to make proper functioning red blood cells. The red blood cells that come out are baby red blood cells, and then they are what's bigger, megaloblasts. Okay, so megaloblasts are erythroblasts with delayed nuclear maturation. You see it over there. So the FBC will usually show you a raised MCV. And when you take a picture of the film, you'll see cells that are bigger. If you were comparing the size to a usual peripheral blood film, you see cells that are bigger. The other thing you see is, you can see I've pointed to something, slide 16. I said hypersegmented neutrophils. So ideally, the neutrophils over there, because you lack folic acid and DNA synthesis is a little bit impaired, the nuclear material over there is impaired. It doesn't go through the proper maturation process, so it becomes hypersegmented. So usually when you do a blood film comment, you see big red blood cells and then you see hypersegmented neutrophils. There and then you have your diagnosis, megaloblastic anemia. Okay. There's also another type of megaloblastic anemia, which we call pernicious anemia. And this time around, pernicious anemia is an autoimmune disorder. And this autoimmune disorder leads to vitamin B12 deficiency. How does it do this? There's a part of your stomach, okay, which is responsible for making something called an intrinsic factor. That part of the stomach is the parietal cells. When you have this autoimmune condition, it leads to inflammation of your stomach, and in so doing, it destroys the parietal cells. Once your parietal cells are destroyed, you are unable to make intrinsic factor. Intrinsic factor is very, 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 very key in absorption of vitamin B12. But if you lack intrinsic factor, which is produced by the parietal cell, your body would never absorb the B12. And that is what happens in pernicious anemia. The autoimmune disorder leads to a gastritis, which is going to lead to destruction of the parietal cells and hence deficiency of intrinsic factor. And then finally, malabsorption of vitamin B12, which will cause you to be vitamin B12 deficient. Okay, so usually your red blood cells are big, and then you have megaloblasts as well, just like the folic acid. So how would you differentiate this from folic acid deficiency? We'll do a serum level folic acid and a serum level vitamin B12. So the one that comes that shows a deficiency, we say, okay, yes, the patient is deficient with this vitamin. Okay. You could also have some conditions where when you do a full blood count, your MCV is high, but I mean, you don't have megaloblast, but the MCV is high. Okay. These patients would usually not have a classic anemia. So if you take a lot of alcohol abuse, or you have a liver disease, or you have a condition where you have reticulocytosis, okay, making abnormally high reticulocytes, you have hypothyroidism, or you use some cytotoxic medications, you can have your red blood cell becoming big, so macrocytosis, but then this time around, you don't have megaloblasts. The megaloblasts are sort of pushed towards the direction of vitamin B12 deficiency or folic acid deficiency. How do you manage this? Once you make the diagnosis and you know that it is due to a folic acid deficiency, let's put your patient on daily folic acid. We know that pregnancy is a state whereby the patients can become folic acid deficient, and folic acid is essential for the maturation of the spinal cord. So without folic acid, you are going to have spinal or neural tube defect or spinal cord problems. Okay, you can even have cleft palate and all that. Folic acid is essential in protein synthesis. So once you are pregnant and we know you are likely to be deficient in folic acid, we'll put you on folic acid 5 milligrams daily. If it's vitamin B12 deficiency, we'll give you IM vitamin B12, okay, or hydroxycobalamin. We'll give you 1 milligram alternate days. We'll do that for 6 times. Then afterwards, every 3 months, you come and take 1 milligram. If your own is because you have an autoimmune disease, it means for life. So once we do that, every 1 month, you come and then you come and take. But if maybe you had some bad gastritis, which is not autoimmune, and it just ate away your parietal cells, once we give you your proton pump inhibitors and the parietal cells come back, we expect that you are going to make intrinsic factor. So they are not going to take it for life, but at least every 6 months you pass by so that we check the level of your vitamin B12. Okay, so trying to wrap up. In aplastic anemia, the major feature here is what we call pancytopenia. Pan means every or all. So here, all the cell lines are what? Reduced. So your HB is reduced, platelets is reduced, white blood cell is reduced, everything is reduced. And when you usually go into the bone marrow, you realize that the bone marrow is very hypocellular. Okay, ideally you expect that the bone marrow will be what? Hyper. You find cells there making red blood cells and all that, but you go into this bone marrow, the bone marrow is hypocellular, and you see a lot of fat cells there. Okay, so bone marrow is not working well. You could have a congenital or an acquired condition causing it. So you check there, you see that Fanconi's syndrome is a syndrome, and as part of the syndrome, all your cell lines can be reduced. Your patients will have low HB, will be bleeding, will be susceptible to infections easily and all that. You could also develop aplastic anemia. I mean, as you are growing up, we'll look for the cause, we'll never find the cause. Some viruses and stuff can also cause aplastic anemia. Some medications can cause aplastic anemia. With those ones, once you treat it, or once you stop taking the medications, your bone marrow becomes cellular again, and then they start making the needed cell lines. Okay. So patients with aplastic anemia, in the beginning of the lecture, I said that in all forms of anemia, reticulocytes will go up. But in aplastic anemia, the bone marrow is actually not working at all. So reticulocytes wouldn't even be produced. So in a full blood count, the classic thing you see here will be reduced cell lines with absence of reticulocytes. Okay. When you do a biopsy of the bone marrow, it looks hypocellular with a lot of fat spaces. How do you manage this patient? You don't have any option. Even if you give this patient erythropoietin, it won't work, because the erythropoietin they're supposed to go and stimulate the cell line to make the red blood cell. It won't work. So you have no option than to transfuse your patient, treat infections, give platelets concentrate and all that. If you are lucky enough and have a lot of cash and you have a suitable donor, we can do a stem cell transplant for you. And the last one is hemolytic anemia. And classic one we usually talk about is sickle cell disease, which we'll be paying close attention to, God willing, tomorrow. But hemolytic anemia basically means that you have red blood cells breaking down, and when they break down, you tend to lose them in your urine, basically. So a classic presentation is a patient coming to you and telling you, "Oh, doc, my urine is like Coca-Cola." Once your patient tells you that, you know you are most likely dealing with the hemolytic anemia. There are various causes. You can have abnormalities in your HB, so sickle cell disease, thalassemia, and all that. You can have an infection. It could be drug-induced. You can have an autoimmune condition. All these things can lead to hemolysis. And once patient is hemolyzing, urine is dark, eyes is dark because it's stained with bilirubin. So your patients would complain of a cola-like urine, and you would pick up pallor and then what? jaundice. And as part of your management, you need to give the patient IV fluid to clear the whole dark urine. And once you are giving IV fluid to clear the dark urine, you need to assess the patient. So you usually do a serial urine collection. You tell the patient that I'm giving you 5 bottles. Whenever you want to pee into a different one and number it. So if you want to pee now, pee into bottle number 1. If in 3 hours later you want to pee in bottle number 2, and so forth. So when you come and inspect the 5 bottles, and then you try to see if your management of giving IV fluids is working. If it's working, you realize that the color in bottle 1 will be deeper than in bottle 2, and so on, so on, so on. That tells you that your management is working. Okay, so hopefully tomorrow we'll talk about sickle cell. So before we go, I have to go for a next meeting, but I'll take questions and then I can drop the link. So any questions?
Sir.
Yes, please.
Hello. Yes,
yes,
I learned that patients with sickle cell trait, the AS didn't. When you do BF on them, you don't normally get a positive result. But yesterday, come out with the symptoms of, malaria and all that. Yeah, when you treat them, they get better. I don't understand why. Yeah.
Okay. Well, yeah. So some people would sometimes tell you that your sickle cell patient, sickle cell people don't get malaria. They do get malaria. They do. And it's essential that you do a BF for them. It's true that sometimes it might be negative, but that could actually be a false negative. And in our practice, you can never be too sure. And with sickle cell, one day they are fine, one day they are not. So once you are picking up, you are doing the test and it's negative, cell itself can cause hemolysis. But then something usually triggers the hemolysis. For sickle cell patient, their usual trigger is an infection. Okay. Apart from the cold weather and all that, the trigger is an infection, and the common infections are malaria. They can get that. So what we do is that when you go to some places, as part of their standard treatment guidelines, they'll tell you that when you have a sickle cell patient coming to you, as part of your treatment, especially if there's hemolysis, give antibiotic and then give antimalarials. Okay, irrespective of the results that comes, you are managing the patient. So give a broad spectrum antibiotic and then give your antimalarial, because we've had cases whereby we've said, oh, this patient doesn't have an infection, WBC is fine. I mean, let's not give antibiotics. And we've lost the patient. And in cases, there have been cases whereby we give and then most of the time the patients recover. Okay, not all of them might mount an immune response for you to have your classic thing to go ahead and say that the patient has an infection or malaria. So as part of your standard treatment guidelines, we'll tell you that treat infection. So treat malaria and then treat any bacterial infection.
Thank you, sir.
Yes, please.
Okay, sir. So please, even if you check for malaria and it's negative, do you have to still treat for malaria?
It depends on your presentation. For
like
any, if you are dealing with a sickle cell patient.
Yes. As in the patient is a sickle cell who is exhibiting symptoms of malaria.
But
the labs are all showing there's no typhoid, there's no malaria.
You have to treat
malaria with antibiotics, with a broad spectrum antibiotics.
Yes. So if your patient, it depends on the presentation, but that's what I'm saying, that even your standard treatment guidelines in most hospitals will tell you give your antimalarials. If you are dealing with an ordinary person who doesn't have sickle cell and the person is running a temperature, okay, you do a malaria test and the malaria test is negative. You have time to look for the other sources of infection. Okay, I'm not saying that when you see it and then it's negative, just start managing for the malaria and stop there. No, you don't stop there. You start managing. Okay, it's better. The saying is that it's better you manage for the malaria than to just wait and say, well, I'm waiting for blood culture, which will come in 3 days. By then your patient is dead and gone. You get it. And it's better you start giving a broad spectrum antibiotic after you've taken a sample for blood culture. We do that for every infection or every condition that we think that there might be an infection. Fever is high. Take a sample for blood culture and start empiric antibiotics, a broad spectrum, whilst you wait for the culture to come. So you don't just take the sample and stop managing. No. Or just stop there and start giving antibiotics. No. You take the sample, and then what you do is when you take the sample, you go ahead to do your other labs and you wait for your results to come. So yes, for me, if it's a sickle cell patient.
What are some of the broad spectrum antibiotics? Antibiotics that.
So broad spectrum antibiotic means that you should be giving something that will cover for gram-positive. Should be giving something that will cover for gram-negative and anaerobe. So in some government facilities I've worked in, because you tell the patient, ideally you can just go and give the patient ceftriaxone, or me, I like brand, so I'll give the patient Rocephin, and I've covered for gram-positive, I've covered for gram-negative, and I've covered for anaerobe. The metronidazole covers for anaerobe. Okay, your Rocephin will cover for gram-positive and then gram-negative. So for me, that is what I will go for. If you find yourself in a place where they don't really have cash, then you can give a medication for gram-positive alone, like a penicillin. So amoxicillin or amoxiclav for gram-positive. Then you give a medication for gram-negative, like Cipro. Okay, if the patient is not allergic to it. So Cipro for gram-negative. Then you give metronidazole for anaerobe. You get it. So once you do that, you've done a broad antibiotic combination whilst you are waiting for your culture to come.
Combining the two, as in amoxicillin and Cipro, you can combine the two.
Yes, you can. Amoxicillin, for me, I don't give plain amoxicillin. I give amoxiclav. Amoxicillin or amoxiclav is only for gram-positive. Cipro is only for gram-negative. So you can give the two. Metronidazole or Flagyl is for anaerobe. So you can add that one. So you are giving 3 antibiotics, and all these 3 antibiotics are going to target different organisms because you don't know what you are treating. And that's why you need to do your culture before. You need to take blood for the culture and then start giving. The results of the culture will come and tell you, oh, we found this. So now go ahead and give only this. You need to do that because your sickle cell patient can come and stay in the hospital for over 2 weeks. So if you don't do a culture and you're just trying anything, anyhow, you are in trouble. Okay. And if you don't start your anti-malarial, trust me, once the patient stays there for like more than 3 days, even if you are still getting a malaria test negative, your specialist will say, let's manage for malaria. Okay.
Doc, in place of the metronidazole, can you give secnidazole?
Well, you can, but you see, for your sickle cell patients, you are more worried about serious infection. Secnidazole is oral.
Yeah.
One thing about your sickle cell patients is you are admitting the sickle cell patient because you want to have a close eye on the patient. So if you are giving secnidazole, it means you are sending the patient home because secnidazole is oral, 2 grams start, go home.
Yeah.
But you want IV, and that's why metronidazole is like the preferred choice.
Okay.
Yeah. So if your patient has money, you can aim at reducing the number of medications. So just combine ceftriaxone and then metronidazole for your patient. Proper brand of ceftriaxone though, so Rocephin and metronidazole for your patient. If your patient doesn't have cash, just do your penicillin plus Cipro plus metronidazole. It will still work. Plus your anti-malarial whilst you wait for your your culture and sensitivity. So when we do sickle cell tomorrow, we'll touch on that. So don't worry.
Sir,
All right.
Yeah.
Sir,
Yes.
this question, like, it's not related to what we are doing, but I think this is the best time for me to ask. Yeah, let's say sporozoid exoelectrocytic stage. When it comes to malaria, does it come with symptoms, clinical symptoms?
Exo what? Erythrocytic stage.
Yeah, yes.
So meaning that they've left the red blood cell.
No, like in a liver stage. Because sometimes
so the hypnozoids. The hypnozoids.
Yes,
okay.
The chisons and those, yeah.
Yes. So once they go, you have them coming out of red blood cell. Some of the parasites will destroy the red blood cell, and that's what will cause the hemolysis in the first place. So at that point, you are very sick, you have symptoms. But after the healing process, some of the parasites are able to live in the liver. Okay. At that point, you wouldn't show much symptoms, but then they can be reactivated. These hypnozoids can be reactivated. So you can have a white man coming to Ghana, develops malaria, you manage the malaria well for the person, and then they don't have malaria outside. So the patient, while the patient is going, your malaria test, your blood film for malaria parasites was negative. Your patient goes, and 3 months after develops malaria-like symptoms. Okay, but meanwhile, before your patient left, you did blood film and it was negative. So you could have that the hypnozoids, okay, or the hepatic stage, they can become reactivated again. And once they become reactivated, then you develop symptoms. But when they are not, and they are just there, you realize that the patient is fine. So there are medications that kill the hepatic, there are combinations with primaquine and all that you can give to destroy the hypnozoids as well. There's a medication like dihydroartemisinin piperaquine, which doesn't only target the the malaria parasites in red blood cell, but also targets the parasites hiding in the liver.
Okay, so in the liver stage, the patient wouldn't show any symptoms?
No.
Okay, thank you.
You're welcome. Most of the symptoms they show is because of the presence of the red blood cell that they found themselves in. And that's why you see we have different type of malaria parasites, and amongst all that is the falciparum that is more crazier because of the effect on the red blood cell that it has. It breaks down the red blood cell, so it will give you severe symptoms. Okay. What we call black water fever, which is the same as intravascular hemolysis.
Okay. Thank you very much, sir.
You're welcome. So tomorrow, God willing, I think, Nick, we're looking at in evening,
Yes, Doc.
All right, okay. So hopefully, God willing, tomorrow we can have a discussion in the evening.
Okay. So that we'll talk about the time and then.
Yes. Okay. I mean, what I've suggested, I think we'll go by it. But if there'll be any change, I'll let you know way before.
All right, Doc.
All right, okay.
Thank you.
You're welcome. Okay, bye. Okay, enjoy your evening.
Sure, Doc. You
too, sir.
All right, thank you.
Okay, thank you very much. Bye-bye.
You're welcome. Bye.